Hello, good afternoon, good morning still, 11:30. So it's time for breakup rooms. So those who want to remain here, it will be forum F1 here. And those who want to go for forum 2 on lesson learned, please adjourn to Sri Perak, the other side of this same level. And then forum 3 on traditional Chinese medicine for healthy aging. Please proceed to level 2, yeah, in Sri Gangsa. Okay, so we will break up for 1 hour until 12:30. Then we all come back to this same room for the lunch symposium. With that, I hand this session to our chairperson.
Hello, testing. Thank you, Mr. Tile. Good morning again, ladies and gentlemen. My name is Philip, and I'll be the chairperson for this session. This is the XXX session, so don't be embarrassed. Stay cool and still please sit down and enjoy the next 3 presentations. If you already didn't know, sexuality is an important component. Emotional and physical intimacy for men and women is important even up to the golden years. Studies suggest that 30% of elderly population have at least one complaint with their sexual function. But most of the elderly people are still interested in maintaining sexual activity and intimacy. The 10th Malaysian Conference on Healthy Aging thinks that this is an important domain. And this forum entitled Sexual Disorders and Aging, we have 3 panelists who will share their perspective, and then we'll open up for discussion. So leave your Q&A to the end. We'll listen to the 3 panelists first, and then we'll have a Q&A. So I'd like to introduce our first speaker, and her name is Dr. Anuradha Subramaniam. She's an obstetrician and gynecologist, and also a gynecology-oncology surgeon. She's based in Hospital Tengku Ampuan Rahimah Klang, and also at Beacon Hospital. She's passionate about women's healthcare, and especially about prevention of cervical cancer. Her hobbies include dancing, watching movies, and gardening. She will be talking to us on sexual intimacy and aging, keeping it up and alive. So, Dr. Anuradha. I think it's a recorded.
Hello, everyone. Thank you for your introduction. This is a very taboo topic, actually, for our Asian society, but it is an important topic to talk about. Sexual intimacy and aging, keeping it up and alive. Now, let's go and see what are the changes we go through as we age. Normal aging brings physical changes in both men and women. The changes sometimes affect the ability to have and enjoy sex, but age alone is no reason to change the sexual practices that you have enjoyed throughout your life. But you may have to make a few minor adjustments to accommodate any physical limitations you may have or the effects of certain illnesses or medicine. What common changes does men go through is decreasing testosterone level. But for men, the significant drop in the testosterone level occurs after the age of 60, compared to women who experience much earlier. So this can affect energy, strength, muscle, fat mass, bone density, and sexual function. Man's sexual drive is more likely to be affected by his health and his attitude about sex and intimacy than by his age. It may take longer for a man to get an erection. Erections can be less firm. Now, what common changes women go through? Most physical changes take place after menopause and are the result of decreased estrogen levels. Common age for menopause for women is about 52, and they can start having decreased estrogen levels as early as age of 40 or 45. And it may take longer for a woman to become sexually excited because of this. The walls of the vagina become thinner and drier and are more easily irritated during sexual intercourse. Orgasm may be somewhat shorter than they used to be, and the contractions experienced during orgasm can be less intense. Not all women experience these problems. Those who do can experiment to find ways to enjoy sex despite these physical changes. Now, there are cultural and psychological involvement in sexuality in aging people. In addition to physical changes, there are cultural and psychological that affect sexuality in later years. Joy in sex and loving knows no age barriers. Almost everyone has the capacity to find lifelong pleasure in sex. It is a taboo, so I think we should overcome this to talk with your partner about these changes and how you are feeling. Many people do feel shy to talk about their sexuality. So don't be shy. Your doctor may have suggestions to help make sex easier. You may have sexual changes as you get older, but some changes may be the first sign of a medical problem. You would not know. So you should talk with your doctor about any changes that concern you. Now, it also involves emotional. Some older adults don't feel as comfortable in their aging bodies, may worry that their partners will no longer find them attractive. This can cause stress and worry. This worry can get in the way of enjoying a fulfilling sex life. Concerns of illness, retirement, lifestyle changes, all of which may lead to sexual difficulties. Now, important component of intimacy or sexuality is touch. Touch is a wonderful and needed sensation. Touch helps us feel connected with others and enhances our sexuality. What are the ways you can go through this? Is get a massage, get hugs with as many people as you can. I know now it's a COVID-19 time. This might be difficult. So with your companion is much better. Hugs, okay? Consider getting a pet. Caring for a pet can help meet your needs for touch. Some studies have shown that older people who have pets to care for live longer. Now, affection. To give and receive affection is a wonderful feeling. If you like someone, be sure to let them know. If someone seems to like you, appreciate it. It is never too late to make new friends and strengthen bonds with long-time companions. Intimacy. Now, intimacy is the capacity for a close physical or emotional connection with another person. Bear in mind, it's not about physical only. Intimacy is also about emotional connection. Intimacy is a great protector against depression. Talking with a confidant can help ease life's problems and rebuild intimacy in your life. Sometimes you may need to turn to your children, siblings, or old or new friends. Don't be shy. Look for another person who's in the same situation as you are. Be available to others. Just as you need people, there are people who need you too. Now, how we can overcome all this? So you have to have, as you want to overcome the physical changes, you have to be physically healthy, go through a lifestyle modification to be a healthy being yourself. So yoga and meditation do help a lot in many aspects of our lives. Hormone therapy for postmenopausal women helps a lot because when a menopause woman goes through a lot of changes, by taking hormone therapy, it can help a lot. But talk to your gynecologist, who can take, who cannot take, okay? And you can use a water-based vaginal lubricant such as KY jelly to reduce vaginal dryness or irritation. Do not use petroleum jelly. A doctor can also prescribe a vaginal cream containing estrogen, which will help reverse the changes in the vaginal tissues. And urinary incontinence, which is very common in women, okay, when they have extra pressure on the belly during sex, can cause loss of urine. So this can be helped by changing positions or by emptying the bladder before and after sex. The good news is that incontinence can usually be treated. So see your doctor. Now see and talk to your doctor if you are suffering from erectile dysfunction. There are treatment for it. So talk to your doctor. Pain can also interfere with intimacy between older people. Chronic pain does not have to be a part of growing older and can often be treated. Joint pain. If you have joint pain, you can rest, have warm baths, and sometimes changing the position or timing of sexual activity can also be helpful if you're suffering from arthritis, for example. People who have had a heart attack or their partners may be afraid that having sex will cause another attack. Even though sexual activity is generally safe, always follow your doctor's advice, okay? Now, some medicines may inhibit sexual response, so ask your doctor about side effects of the medicine you are taking. Maybe the doctor can reduce your dosage or prescribe a different medication to avoid all these side effects. But however, always consult with the doctor first. Don't do it yourself. Now, there are procedures that involve changes in physical appearance that need not put an end to sexual pleasure. So women may go through a hysterectomy, removal of the womb, or removal of the breast, mastectomy for breast cancer, or removal of the prostate for men. All this can affect your sexuality, but it doesn't have to, okay? If before the surgery itself, if you have concern, talk to your gynecologist or your surgeon. Or if you're suffering after the surgery, please talk to your doctor as well. Communicating openly about your fears and expectations can bring you and your partner closer together and help you overcome these barriers. Now, drink alcohol only in moderation because large amounts of alcohol may decrease your sexual performance. Too much alcohol can cause erection problems in men and delay orgasm in women. Now, coming back to sexuality is often a delicate balance of emotional and physical issues. How you may affect what you're able to do and what you want to do is all depends on you. So many older couples find greater satisfaction in their sex lives than they did when they were younger. Some may not have problem at all, or for some, this is not important part of their life, okay? So they have fewer distractions sometimes as when you age because you have more time, privacy, no worries about getting pregnant, and you can have greater intimacy with a lifelong partner. Now, staying sexual. Sexuality should be recognized as a positive aspect of life, okay? Take time to enjoy each other and to understand the changes you are facing. Don't be afraid to talk with your doctor if you have a problem that affects your sex life. If you sense changes in your partner's attitude towards sex, don't assume they are no longer interested in you or in an active sex life. You may find that affection, hugging, kissing, touching, and spending time together can be just what you need or a part to greater intimacy and sex. Okay? So these are my reference. And thank you very much. So I hope you enjoyed the presentation. And I just want to remind you all, sexual intimacy is important. Doesn't matter for man or woman as you age. Thank you.
We will move on to the next speaker, and again, as I mentioned earlier, the questions and answers session will be after our third speaker. So our second speaker is Associate Professor Dr. Sivakumar S. Balakrishnan. He is with the Royal College of Surgeons, Penang Medical College, and also Associate Professor in Obstetrics and Gynecology. He's also a visiting consultant with Penang Hospital and Penang Adventist Hospital. He is also the founding secretary of Malaysian Urogynecology Society and is currently the vice president of the Malaysian Urogynecology Society. He's a member of the International Urogynecology Association and is currently serving as the Southeast Asia representative of the International Advisory Board of the IUGA. And he's also the incoming president of the Penang Medical Practitioners Society. So I'd like to invite Associate Prof. Dr. Sivakumar to speak to us on common pelvic floor disorders in postmenopausal women. Prof. Sivakumar.
Thank you, Mr. Philip, for the kind introduction. First of all, I'd like to thank the organizers for inviting me. I think looks like I'm the only one coming in for face-to-face lecture in for this particular symposium because I'm from Penang. So thank you very much. Okay, so without wasting much time, I would talk about pelvic floor dysfunction in menopausal women. I think the previous speaker, Dr. Anuradha, had actually spoken about sexuality in menopause, but from a urogynecology perspective, I'm a urogynecologist, so when the topic was given to me, so I was thinking about what are the problems of pelvic floor in postmenopausal women, basically talking about aging women as well. Right, so I think Dr. Anuradha has spoken. I'm not going to talk too much about it, but quickly just looking at this, menopause is obviously at a point of time when the menstrual cycles permanently cease due to natural depletion of ovarian oocytes due to aging. And it marks the end of fertility. Average age of menopause is usually around 51. And as I said, depletion of follicles in the ovaries. But the most important thing, the major estrogen secretion from the ovaries stop. And this will eventually lead to various effects on the woman. So, but this lecture, I'm going to focus more on the pelvic floor effects of menopause. So, menopause reduces the effect of estrogen on the vagina, the pelvic floor muscles, the urethra, the vulva as well. So, estrogens overall are vasoactive hormones. They help to increase blood flow, help to maintain the low pH by increasing glycogen in the vagina, which increases the lactobacilli and lowers the pH, helps to protect against UTI and vaginitis, and also help to influence the central neurological control of micturition. In menopause, there is downregulation of the estrogen and progestogen receptor in the vaginal wall of postmenopausal women. Therefore, it can also affect the detrusor function of the bladder through the modification in the muscarinic receptors and inhibition of the extracellular calcium ions into the muscle cells. Estrogen receptors are found in the female squamous epithelium of the proximal and the distal urethra, vagina, and the trigone of the bladder, and also at the anal canal, and also expressed in the paraurethral tissues, urethral sphincter, uterosacral ligaments, and the pelvic floor musculature. For the urinary tract, estrogen has an advantage effect on the vascular mucosa of the lower urinary tract. So therefore, it provides an explanation why successful use of estrogen in treating some of the conditions of the lower urinary tract dysfunction in postmenopausal women. Pelvic floor muscles, obviously we know muscle mass is lost with aging. It is thought that the average skeletal muscle strength is at the peak at the age of 20 to 30, deteriorates by 5% per decade. So pelvic floor muscles not immune to this aging process. This has been shown by various studies that showed that striated muscles thickness have actually reduced, especially in the urethra, over the years. So common pelvic symptoms from the genitourinary syndrome of menopause includes atrophic changes of the vulva, vagina, and the lower urinary tract. This can cause vaginal dryness, vaginal irritation, and itching. Other urogenital complaints can include frequency of micturition, nocturia, urgency, stress urinary incontinence, and also urinary tract infections. So what are the common pelvic problems associated with menopause? This could be urogenital atrophy, sexual dysfunction. I think previous speaker has spoken much about it. UTIs particularly, and the recurrent UTIs that we commonly see, urogenital prolapse and urinary incontinence. So for urogenital atrophy, what we see is that there is, when the lining of the vagina gets drier and thinner. 15% of female population experience symptoms of vaginal atrophy before menopause, whereas 40 to 57% actually have postmenopausal have symptoms. So the atrophy leads to vaginal dryness, irritation, and soreness. So obviously, you know that sexual dysfunction, so they may have difficulty and pain. Can lead to postmenopausal bleeding as well, and lower urinary tract symptoms, as I mentioned earlier. Sexual dysfunction can include low sexual desire, poor lubrication, dyspareunia. Again, dyspareunia is painful sexual intercourse, and this is due to vaginal dryness and the atrophy of the vagina. UTI, I think this is something that most doctors actually see, particularly in the general practice, and especially in the menopausal age group. A lot of women actually present with UTIs, right? And it is because of reduction in vaginal normal flora in the menopausal period, because the lactobacilli, which I have told you earlier, which ferment glycogen and create lactic acid, is reduced. Thereby the pH is actually increased and promotes possible infection. So the other thing about UTIs are the recurrent UTI. It's quite common in postmenopausal women, and the most accepted clinical definition is more than 3 episodes in the 12-month period. So I do see a lot of referrals for recurrent urinary tract infections for women in the menopausal age group. Prolapse, of course, as a urogynecologist, this is probably our main problems that we see. Weakness of pelvic floor usually leads to a variety of prolapse. It could be uterine prolapse, bladder prolapse. You will have rectocele, rectal descent, or even patients who've had previous hysterectomy, they may present with vaginal wart descent. And the urinary symptoms, particularly lower urinary tract symptoms, this is another common problem that we see in this postmenopausal age group. Particularly they present with urinary frequency, urinary urgency, particularly disturbance in the night, nocturia. They can have incomplete voiding, and also associated urinary incontinence. This could be either in the form of urge urinary incontinence, stress urinary incontinence, or a mixture of both. So how do we manage these problems? Basically pelvic floor disorders in menopause. Right, so again, usually we'll go back to the standard way of management. We take the history, check when they underwent menopause, how long they've been menopause, whether it's 5 or 10 years or whatever. And then we check whether they've actually had any hormone replacement therapy. We check about their main complaint. And then we examine them. Of course, general examination as a gynecologist, we definitely look for, examine the abdomen, check for any presence of mass. Pelvic examination is done, particularly looking out for any atrophic changes. Investigations obviously will include pap smears. You may need to do biopsy if there's required, if there's an abnormality. And then we do ultrasound. Pelvic ultrasound to check for the uterus, check for the endometrial thickening or any abnormality. And most definitely we're probably doing a urine test, both FEME and a culture sensitivity. Others in the part of a management may include bladder diary. This is basically looking at their input-output chart, how much they urine, whether they have any any incontinence. And investigations, invasive may include diagnostic cystoscopy or a urodynamic evaluation. These are invasive, so we usually reserve it for patients who have indications. Overall treatment for pelvic floor disorder, obviously we need to talk about counseling, and everything we start with counseling, conservative management, encourage healthy lifestyle, make sure that they take adequate hydration. I particularly talk about hydration and also tell them not to take too much of fluid at night. I think that's something that a lot of women do. They drink a lot of water, particularly they do it at night, and they end up getting up in the middle of the night with nocturia. So we tell them by 8 o'clock, cut down your fluid, drink enough water, but cut down your night intake of fluid. And then we can send them for pelvic floor exercises. And then I think Dr. Anuradha did mention about vaginal lubricants during sexual intercourse. HRT obviously is controversial over many years now, but we tend to use it for those women with menopausal symptoms to reduce the symptoms, and definitely those with premature menopause, they actually will benefit. Time limit usually we use for about 5 years quite safely, and before the age of 60, but I think once the age of 60, then we probably counsel them to stop. Can also be used for those patients with low sexual drive. Local applications, vaginal estrogens, vaginal moisturizers. Unfortunately, I think now the vaginal estrogen, the Premarin cream is, I think, is no longer in the market. So I think we are still struggling. Most urogynecologists and gynecologists are struggling to find alternatives for this, but you can use moisturizers, right? And the estrogen creams were actually quite good and effective to relieve common vulvovaginal atrophy related symptoms, and it's quite improved a lot of these urinary symptoms. And we need adequate counseling before starting the estrogen therapy. Both I usually give intensive therapy followed by maintenance therapy. Laser therapy, I'm sure some of you are familiar with laser therapy. This is something that is being advocated by some of the aesthetic doctors particularly. It's supposed to be useful because it helps to regenerate the vaginal mucosa and submucosa and increase collagen synthesis. All right, and this is used for, they use this microablative fractional CO2 laser, and this is seem to be quite useful in treating vaginal atrophy. So you can, if you have and you want to try, you can. But of course, this is a bit expensive, and care has to be taken by the people who are using this therapy. For UTIs, I think definitely simple thing. Of course, you diagnose antibiotics, alkalinization of urinary pH. So that's quite standard. But more interestingly, for recurrent UTIs, how do we manage? I think a few things that we need to talk about is basically discuss about self-hygiene. Cranberry, I think I actually advocate cranberry tablets. This is quite found to be useful to reduce the incidence of recurrent UTIs. And if needed, then you probably need to give them prophylactic long-term antibiotics. Just a few more minutes. For prolapse and stress urinary incontinence, usually we will apply pelvic floor exercises, conservative management, or even ring passages. I'm sure you're familiar for prolapse. And if that doesn't work, then we have a variety of surgical options for both prolapse and stress urinary incontinence. So in summary, menopause brings about significant changes in the pelvis and the pelvic floor, leading to multiple symptoms that can affect the quality of life. I think the awareness among healthcare practitioners is very important. And as I think Dr. Anwar did mention that a lot of pelvic floor dysfunction can be treated and just not thought as part of aging, just have to live with it. I think no longer the case. I think in Penang, I think we do see a lot of patients who are quite aware, and they do come and seek treatment, and we can plan appropriate therapy for them. So with that, thank you very much. Thanks for the opportunity, and I think we'll stand by for the questions later. Thank you very much.
Thank you, Professor Sivakumar. Moving on, we will invite our third and last speaker, who is Dr. Kanesh Kumaran, who is a lecturer and clinical specialist in the Division of Urology, University Malaya Medical Center, Kuala Lumpur. He previously worked as a general surgeon in Hospital Muar, and he has a special interest in men's health and renal transplantation, and is currently involved in ongoing research work related to this. He speaks to us today on sexual disorders in aging from a urological perspective. He's virtual and live. So inviting Dr. Kanesh Kumaran.
My audio is clear. Okay, so a very good afternoon to the distinguished speakers and participants. I would like to thank the MHAS organizers for giving me the opportunity to talk in this platform. I have no disclosures, and the objectives for today would be touching on the common etiologies of sexual dysfunction in the elderly population from a urology perspective. So mainly looking at the male population. So I've broadly divided sexual dysfunction into these 4 groups, but this is for simplicity for today's talk. This is not an official classification. And they comprise of erectile dysfunction, disorders of ejaculation, hypoactive sexual desire disorder, late onset hypogonadism. We will start off with a case just to gauge everyone's attention. A 62-year-old man who recently underwent coronary artery bypass surgery, smoking 1 pack of cigarettes a day, and it's been increasingly difficult for him to achieve a firm erection. He has been cycling in the past, but after the surgery, he has stopped, and the physical examination is unremarkable except for an enlarged prostate. The image on the left is actually a validated assessment tool when it comes to this, and it is by the European Urological Association on the hardness of erection. So it's divided into 4, the first one being soft, and the second one being hard but not enough for penetration. The third one, hard, sufficient for penetration, but it's not the optimal hardness. And the fourth one is optimal hardness. So what are the prevalence of erectile dysfunction in general population? There was a study by Feldman in the male aging study, which showed an overall prevalence of 52% in non-institutionalized men, ranging from 40 to 70 years old. Another study showed 19.2% prevalence, but there was a steep age-related increase from 2.3 to 53.4%. So now comes the question, what is the prevalence in Malaysia? From what's expected, it is much higher than our other counterparts. It's approaching 70 to 80% in a small sampled population. And bear in mind, these are the groups of help-seeking patients, so the real numbers could be much higher. So what are the risk factors? It shares similarity with the risk factors of ischemic heart disease, with the added drugs that cause this, which are thiazide diuretics and beta blockers, lower urinary tract symptoms, chronic diseases, obstructive airway disease, as well as chronic kidney disease, to just name a few. And there has been a significant interest in erectile dysfunction and its association with cardiovascular health. There's a lot of debate now that erectile dysfunction is actually the onset for, and this has to be seriously looked into. There are many studies to support this, and something to pay attention when seeing a patient with erectile dysfunction in clinic. So these are the approved treatments available for erectile dysfunction. Of course, goes without saying, lifestyle changes and modifying risk profiles becomes the utmost important, followed by oral medications, which come in the group of phosphodiesterase 5 inhibitors, vacuum devices, intracavernosal injections, intrauretral inserts, penile implant. And of this, the most commonly used would be the PDE5 inhibitors. So PDE5 inhibitors, we have 4 approved for clinical use: sildenafil, tadalafil, vardenafil, avanafil, and all are available in Malaysia. And no, Pfizer did not sponsor. This is actually the classical blue pill that we always refer to. And the successful intercourse rates reported between 60 to 80%. The next would be vacuum device, vacuum assisted erection. And by the concept of vacuum, it helps in attaining erection, followed by the maintenance of by application of rubber band at the base of the penis. And the success rates are reported from a wide range, 20 to 90%. And that is because this modality may not be the best option for everyone. And just on an interesting note, while preparing for this presentation, I actually came across a lot of online commercially available penile pumps. And I have to say, despite being cheap, the safety and the efficacy is still needs to be questioned. Next would be the intracavernosal injections, and this has very good success rates, more than 85%. The patient self-administers prostaglandin E1 into the corporal body just prior to a sexual activity. And most of the time, the patients actually complain issues with pain, hematoma, and it is somewhat unpleasant for the patient, causing discontinuation. The next in line would be intrauretral inserts, and the success rates are 65%. And these inserts are similar prostaglandin E1 derivatives, and using an applicant, the patient self-inserts. While last but not least would be penile implant, the most robust treatment in the erectile dysfunction patient. There are many types, and the two general headings in this group would be the self-inflatable that comes with a pump and a reservoir, or the adjustable malleable. The downsides to this penile implant would be the cost issue. In Malaysia, we are looking at a cost of 30,000 to 40,000 ringgit. And it's relatively invasive because it's an open surgery. And there's a risk of implant infection that may require removal of the implant. So a lot of money can actually go to waste. But despite all that, it is actually a foolproof way of treating erectile dysfunction. And high satisfaction reports have been reported by patient and partners, more than 95. And consistently, certain papers have actually said that it is close to 100%. So just before moving on to the subsequent entities, there are frequently asked questions in my erectile dysfunction clinic. Is it safe to take a PDE5 inhibitor if I have coronary artery disease? There are numerous studies available outside, and I chose to show a few, and all of which did not show an increase in the incidence of serious cardiovascular events or subsequent myocardial infarction, provided the coronary artery disease is stable. This is in line with the Princeton 3 consensus on the management of erectile dysfunction and cardiovascular disease in patients who had recent myocardial infarction less than 2 weeks to sexual intercourse, because there are other confounding factors that actually increases stress. So the answer is no. So moving on to the next subset would be ejaculatory disorders, and I've truncated this just to in the interest of time. Premature ejaculation, retrograde ejaculation, and ejaculation, painful ejaculation. Of all these conditions stated, premature ejaculation becomes the most common presentation to men's health clinic. And the negative impact of premature ejaculation is beyond sexual dysfunction. It actually has a detrimental effect on self-confidence, relationship with a partner, and it may actually even lead to mental distress, anxiety, embarrassment, and depression. So unfortunately, the etiology is unknown, but it suggested biological and psychological connection, which includes anxiety, penile hypersensitivity, and serotonin receptor dysfunction. So the approach is basically to establish diagnosis, and the most important aspect in the history would be what we call intravaginal ejaculation latency time. It's a very high-fi term, but what it simply means is how fast the male patient actually ejaculates. And the diagnostic feature here is less than 1 minute. So management of premature ejaculation has been always been very difficult, and the advances in recent medicine has yet to shed a big breakthrough. But there are definitely ways that we can actually advise our patients, and again, coming back to lifestyle and behavioral modification. So, one of the advice that we actually give is for the patient to actually masturbate before embarking on sexual intercourse. And there are evidences for that, but it may not be strong. And the next option would be application of topical anesthetic creams. This would be applying an anesthetic cream on the penile head and subsequently covering it with a condom, because you do not want your partner to be numb, and the condom actually prevents that. And the next option here we have is PDE5 inhibitors. Again, the PDE5 inhibitor here is not a solution for premature ejaculation, but it is more of boosting the self-confidence of the patient. And in the event that the patient does experience a premature ejaculation, to achieve a subsequent ejaculation is much easier in reported studies. The Dapoxetine is a short-acting SSRI, serotonin inhibitor, and it is approved by the European Union, not by the FDA, and shows good response. And there are other off-label medications for premature ejaculation, which are not validated and has a mixed response, which I would not discuss in this platform. Next would be a hypoactive sexual desire disorder. This is actually a recognized entity now. This is where patients don't have the sexual desire or erotic thoughts for sexual activity. And the prevalence are about 5% in general population. So Levine et al. Proposed that there are 3 components to sexual desire. One is the drive, the second is motivation, and the third is wish. And many would say that testosterone seems to be essential for a man's sexual desire. But what is found through research is sexual desire does not directly relate to circulating levels of testosterone. So an elderly patient may have normal testosterone levels, but he has no motivation or wish to engage in a sexual activity. The causes for HSDD is many, and I've included some of the important ones. Androgen deficiency goes without saying, anger, anxiety, relationship conflicts, epilepsy, antidepressant therapy, as well as aging. So the treatment would be addressing the underlying etiology, and to a large aspect, or the large part of it is psychosocial and behavioral aspects. And the last entity to be discussed today would be the late onset hypogonadism. We abbreviate it as LOH, or known as testosterone deficiency. So in healthy aging men, there's only a small gradual decline in testosterone up to the age of 80, and it accounts for a very low percentage. But we are now seeing more and more patients who are coming in with symptoms of hypogonadism. This is when the internal hormonal balance is tipped off by other confounding factors, such as concentration in the body, comorbidities, type 2 diabetes, and you throw that with an increasing age, it just becomes a catastrophe. So frequently, this condition is associated with the menopausal symptoms that the female counterparts actually experience. And there is a term that we actually use, which we call it as andropause. And the symptoms are overlapping, where they have sexual symptoms, reduced libido, and goes without saying, erectile dysfunction comes in there, and decreased in physical activity. They do not want to be involved in strenuous exercises, psychological low mood, sleep disturbances. And to assess this patient's history physical examination, that should include the digital rectal, because sometimes underlying prostate problems can actually contribute. Blood levels that we are interested in would be the serum testosterone level, which is diagnostic for this condition, which is less than 8 nanomole per liter in 2 separate readings taken in a fasted condition an early morning sample because testosterone has a circadian rhythm. And along with the serum testosterone, we also take the hematocrit as well as PSA, and the importance of which would be shown in the subsequent slides. And the EAU guideline 2022 strongly suggests only to screen for late onset hypogonadism in symptomatic men. So the treatment for low testosterone is simply by giving testosterone. So it comes in various forms, and you can broadly classify them into topical, parenteral. But again, modifying risk profile becomes of paramount importance. And not all patients are suitable for testosterone therapy. Untreated breast and prostate cancer in male patients, hematocrit more than 54, family history of venous thromboembolic conditions, uncontrolled CCF, ischemic heart disease, severe lower urinary tract symptoms, and fertility desire. Because we cannot assume that elderly population, they do not have the same desires. And when it comes to fertility, then testosterone is known to impair spermatogenesis. So there are other options for this population. It may not be as efficacious as testosterone, but it is comparable. So when speaking of testosterone treatment in men, the similar concerns in treating postmenopausal women with hormone replacement therapy. So in men, we know that the prostate gland is linked to the hormone testosterone. And by us giving testosterone, there are concerns regarding worsening of benign prostatic enlargement symptoms. And there are numerous studies, and I've included a few. It shows no difference in the symptoms, no difference in the prostate growth, and it does not affect their BPE symptoms. And we know that one of the backbones of prostate cancer treatment is actually to cut off the supply line of testosterone to the cancer. That is, you cut off the testosterone, which is in, which we call it as androgen deprivation therapy. So now the concern is you are giving patients testosterone. Would that give rise to increased prostate cancer incidence? And the answer is no, and this has been also seen in various studies. Now coming to cardiovascular health. There is no randomized controlled trials that have provided a clear answer to this, unfortunately. However, what is safe to say for now, there is no increased risk up to 3 years of testosterone therapy in stable ischemic heart disease patients, those patients who are not experiencing frequent anginal attack, not experiencing, who recently experienced recent infarct or angina. So with any medication that makes one feel good or improve, there is always a concern of abuse. So the EU guideline has been very clear. The use of testosterone therapy in eugonadal men is not indicated. Do not use testosterone to improve body composition. Lifestyle modification and risk factor modification, I think, has been seen over and over again of its benefit, and should always take precedence over any medical or invasive intervention as first-line management. And goes without saying from the previous two speakers, the understanding and the importance of psychosocial balance and a healthy spousal relationship. So often at times, my advice to patients would be, there's no amount of Viagra could help your erectile dysfunction if your relationship is not good with your wife or partner. So I guess being nice to your partner or wife is something very important. And there are treatment available for most sexual dysfunctions, and elderly patients should be encouraged in seeking them. And last but not least, age is just a number. With that, I thank everyone.
I guess you didn't hear that. I'll repeat that question. How do you prepare couples for intimacy changes that come along with aging?
First, we have to get to know what is the issue. If the issue is with the relationship because of emotional changes, then they have to address that with the couple counseling. But if the cause of the intimacy issue is because of medical problem, then we have to address the medical problem first. So if you say in a example, the female had pelvic floor issues, then she should see a gynecologist, get the issue addressed, and then she can consult the gynecologist as well. Okay. And the thing is, with our Asian, they still have taboo about this topic. So sometimes the female doesn't want to talk about this, but the male partner want to talk about this. So actually, they have to talk to each other, what they want, what they need. Actually, it's very important for couple to talk to each other.
Yeah, I mean, I think it's beyond just the couples itself. I think it's healthcare professionals need to be able to discuss this with their own patients as well. And the conversation should actually start there, perhaps. I have another question I'd like to address to Prof. Sivakumar. You know, in this day and age, we have a lot of investigations that are done looking at hormonal assays. Under the list of investigations that you gave earlier, there wasn't any mention of this. Is this of any benefit, looking at estrogen levels, progesterone levels, and all of that? Is that of any benefit? And Johnson as the go-to for sexual problems till sildenafil and the rest came onto the scene. How relevant is psychological therapies and behavioral treatments? It's almost like it's swept under the carpet and not important anymore.
Thank you for the question. I still put a lot of emphasis in the behavioral and lifestyle modification before going into pharmacotherapy, because a lot of these patients are still actively smoking, and some of them the exercise aspect of it is not being addressed. And to start with, the household condition is also not conducive. Some of them actually relate that they have about 3 to 5 kids at home, and each have their varying needs. And when it comes to time to intimacy, both parties are actually tired and not interested. Very difficult for them to actually take a weekend off, and with the added stress of work-related issues. So all this thing actually confounds. And what we must understand with the pharmacotherapy or the PDE5 inhibitors is it is a rule that it only works with sexual stimulation. So sexual stimulation can be auditory, can be visual, can be olfactory, can be tactile. So without any of this stimulation, some of the patients actually expect that with the previous issues of erectile dysfunction, they want to take these medications and then somewhat surprise their partner. And the erection doesn't come because the stimulation was never there. So I always tell them that there must be a good communication between the husband and the male and the female, whereby it must be a planned discussion. The partner must understand that this medication is being taken and what are the support needed for its effectiveness. So that's my take in it.
Yeah, I would agree. I think it's important to look at couple therapy rather than just individual. Very often when individuals come on their own, they're not actually communicating with their spouses about their sexual dysfunction, hiding it and trying to take pills on the sly. But in actual fact, they could actually be working together to work the intimacy without the need of pills as well. Anyway, I think we have come to the end of this session. Thank you everyone for your attention, and thank you once again to our speakers for the wonderful presentation and for the very informative slides and presentation. Thank you once again. I'd like to now hand over to the next chairperson, lunch symposium.